Okay, welcome everybody to today's Grand Rounds. For those of you who I've not met, my name is Richard Gilbertson and I chair the Department of Oncology. We've got two great talks today, very appropriately for Antibiotic Awareness Week, which I believe starts tomorrow. We're going to start with Sunny Kashine, who's going to talk to us about how antibiotic aware are you. So over to you, Sunny. Thank you. Just to remind people that we're recording this, but also please put any questions in the chat as we go along, and I'll read those out at the end. Thank you very much.
Thank you for the introduction. My name is Sunny Kashine. I'm one of the ID and microbiology registrars here at Addenbrooke's. And as many of you are already aware, starting tomorrow is World Antimicrobial Awareness Week. It runs every year from the 18th to the 24th of November, rain or shine. And as per tradition, the microbiology department gets given this grand round slot to offer you an update about where we are when it comes to antimicrobial resistance and stewardship. So this year we've chosen to reflect on the impact that COVID-19 has had on our use of antibiotics and on AMR, both nationally and locally, and also take stock, as I think I'm right in saying that a lot of other specialties have been doing this as well. Take stock in what COVID-19 has meant for our goals and targets that we set ourselves and we're working passionately towards pre-pandemic, and we're all upheaved somewhat. So the way I'm hoping to do that is to whiz you through some of the data and targets for AMR pre-pandemic, so from up to about 2019, then present a case from which I hope to tease out a number of talking points that we will use to look at the data in 2020 and 2021. And finally, I'm going to wrap up by just discussing some of the perhaps concerns and challenges that we have ahead of us, and open the floor to any questions and comments. So pre-pandemic, from a perspective of engaging with AMR, I think the UK really was at the forefront. It was ahead of many other countries. AMR was at the forefront of UK policy. And Dame Sally Davis, shown here on the left-hand side, played an important role in ensuring this was the case. She is currently, as many of you may know, the Master of Trinity College here at Cambridge. But it was really in her role as Chief Medical Officer in 2011 when she decided to dedicate her entire annual report to AMR that this led to a kickstart, shall we say, in the discussions surrounding AMR. And in 2013, we got our first 5-year strategy that was aimed at AMR. And we are now in that new iteration. So you can see here, it's our 5-year National Action Plan for 2019 to 2024. And what I've put on the side here is just the targets of some particular targets that are relevant to us in hospital. So you can see that there's an aim to halve healthcare associated gram-negative bloodstream infections. Also, we're looking at specific drug-resistant infections and trying to reduce them by 10% by 2025. There is this quite a new sort of target, aiming to be able to report the percentage of antimicrobial prescriptions and that are supported by diagnostics, and this is hoped to be possible by 2024. So really aiming at strengthening lab diagnostics and AMR surveillance. And finally, an overall target to reduce antimicrobial consumption. But if you see, there's a difference between community and hospital, and the one that applies to us in hospital is this 10% fall in watch and reserve antibiotics from the baseline in 2017. And what this watch and reserve is referring to is the WHO antibiotic classification tool, where basically the access antibiotics, they should be ideally our first or second line choice antibiotics for treating common infections. So this might be your narrower spectrum antibiotics with lower resistance potential, for example, something like amoxicillin. Your watch antibiotic is your biggest category. There's almost 110 antibiotics in this category. And they are very much in use, but they have a higher resistance potential. So if possible, we want to be using them only for really specific indications. So that might be your broader spectrum, something like tazocin. And our reserve category is obviously our nuclear option, if you will. It's our last resort options, and we really want to be saving those for confirmed multi-drug resistant infections. So that's where something like your newer antibiotics like fidrocol might be, but also some old antibiotics like colistin that are being repurposed might fall. So how are we doing? So these graphics are all taken from the SBAR report. SBAR stands for English Surveillance Programme for Antimicrobial Utilization and Resistance. And actually the 2020 to 2021 report has come out today. So some of you might have seen there is picked up, for example, by the BBC. So the pictures up here, I'll draw your attention first on the right-hand side. The pill pot shows overall consumption of antibiotics in the UK. I'd just like to take a moment to discuss this metric, so DDDs per 1,000 inhabitants, because this is something that we'll be using repeatedly to look at all of our results, really, all of the graphs that I'll be presenting. So DDD stands for defined daily doses, and it's basically a metric that aims to standardize drug consumption and allows you to compare different antibiotics that will have, for example, different numbers of antibiotic doses per day. So overall, we're doing well in terms of reducing our antibiotic use, but if I draw your attention down here, most of those wins have been in the community, and you will see that in hospital inpatients, actually antimicrobial prescriptions have gone up by 13.4% between 2015 and 2019. On the left, I'm showing bloodstream infections for key pathogens, basically those that are part of our surveillance, and that will be gram-negative bacteremias, Staph aureus, strep pneumobacteremias, and you can see that it has been steadily increasing up to 2019. And perhaps more worrying still is that the resistant versions of these key pathogens have also been increasing in proportion. Looking at this in a little bit more detail, this is a graph taken from PHE. So this is mandatory reportable infections. It's mainly bloodstream infections, but I'll talk you through each of them. And we're looking at sort of a rolling 12-month totals here and a percentage change. So at the bottom here, we've got in the red, we've got C. diff, which obviously isn't a bloodstream infection, but is healthcare associated. This red one's C. diff, and you can see that we've made good improvements over time. The blue one here is MRSA, and again, MRSA bacteriums have been targeted for reduction, and you can see that over time, with some blips, there's been sustained reductions. But I'd like to draw your attention to the other bits. So here we have E. coli bacteremias, which you can see are steadily increasing up to 2020. And also, which is not talked about very often, is MSSA bacteremias here in the lighter blue. So a reduction in MRSA, but a steady increase in MSSA. Now these two here, they're Klebsiella in green and Pseudomonas bacteremias in pink. You can see that they start later because they weren't part of the surveillance initially, and they're sort of a new target that's been brought in. So we don't have data before this, but again, they're showing sort of an increase. So we had our work cut out for us pre-pandemic, and then the pandemic happens and everything got upheaved. So the case that I'm going to be presenting is that of a 47-year-old man of Indian origin, normally fit and well. He gets a positive PCR test for SARS-CoV-2 on the 8th of January. So this is pre-vaccination. It's too soon in the vaccine rollout. So this is a case of unvaccinated COVID-19. He presents 7 days later to hospital with a raised respiratory rate and saturations that are sitting between 93 and 94% on room air, but he's desaturating on mobilization. His blood tests are shown here. He's got lymphopenia, but normal neutrophil counts and a good going CRP. He gets given a whiff of oxygen. He also gets started on coamoxiclav, which may not have been indicated in this particular case given the normal neutrophil count. and he also gets the remdesivir and dexamethasone, which is the standard of care. And you can see his chest X-ray here. There's haziness by basally. I think there was some concern by the admitting team that there may be a developing pneumonia, perhaps this shading here. Unfortunately, he continues to deteriorate from a respiratory perspective, and he gets transferred to ITU. He gets briefly put on an MRE, he's proned, and he gets escalated to PIP-TAS. His chest X-ray now you can see has progressed, and it's much easier to see the infiltrates now. They're consistent with the COVID pneumonitis. He is intubated shortly afterwards. At this stage, a procalcitonin gets sent, which is 0.3, the cutoff being 0.5, so it's low. And also a bronchoalveolar lavage gets done, and it's sent for microarray. Now, many of you may well be familiar with the microarray from maybe clinical work or from research, but for those who haven't come across it, particularly those who may not have worked in critical care or respiratory, this is what a microarray card looks like. It's called a Tachman array card in terms of its brand name, so you might hear it referred to in that way as well. And it's a way of doing sort of real-time PCR for multiple targets at once, so it gives fast, reliable results for a really big range of pathogens, and it's bacterial targets, but also fungal and viral targets. The samples are loaded up here at the top, so you can do up to 8 samples in one go. And at the bottom here is where sort of the individual PCR targets are. So each one of these is going to be a separate target and a separate PCR reaction. And the EPIC readout looks something like this. This is actually a truncated version, but it basically shows you a long list of everything that's been tested and whether or not the DNA or the RNA has been detected. And in this particular case, the microarray was negative. It showed SARS-CoV-2, which was expected, but no other bacterial or fungal pathogen was identified. So actually, this in conjunction with the low procalcitonin meant that the antibiotics were stopped. Unfortunately, about a week later, he does go on to have a fever spike with an inflammatory marker rise as well. Procalcitonin wasn't done at this stage. He gets restarted appropriately on PIP-TAS and gets blood cultures sent from all the lines, and as well as a repeat BLL culture. They're both a urine culture that are negative. And the blood culture from one of his lines, I think it was a CVC line, grew a Klebsiella pneumoniae. You can see the results here of the sensitivities. It's a pretty sensitive Klebsiella. So he gets his antibiotics changed to cormoxiclav because we now know that it is sensitive. He gets his line changed and he completes 7 days of antibiotics. So I'm going to stop the case here for the time being, but just to briefly say that actually this patient went on to have a good outcome. He was discharged from ITU a couple of weeks later. He had a difficult respiratory wean and did get a tracheostomy, but was discharged home. So what I'm hoping to tease out is antibiotic use in COVID-19, community and hospital-acquired bacterial infections and what types we get in COVID-19. And very briefly, although I'm aware of time, I'll just talk about ventilator-associated pneumonia. So are bacterial infections of COVID-19 common? The short answer to that is no. I'm showing here results from the systematic review that was done very early on in the first wave. So it's mainly data from China and from Italy, but this has subsequently been shown in UK trials as well, UK studies as well. So co-infection rate, that means having COVID-19 plus a bacterial infection when you come in, you only have about 3.5% of the patients in this cohort that have that. Secondary infection refers to bacterial infections, whether that be respiratory or bloodstream infections that occur over 48 hours from admission. So really your hospital-acquired cohort. And that was 14.5%. However, in contrast to that, 71% of the patients in this cohort received antibiotics. So there is a definite discrepancy over the amount of antibiotic use that we had and how common bacterial infection is in COVID-19. And this was really shown when we look at antimicrobial prescribing both nationally and in our trust. So this is data from PHE, and you can see that there is a blip in antimicrobial prescribing rates around the time of the pandemic. The black here is national data, the purple is CUH data, and you can see that it matches the trend perfectly. On the right-hand side, I've basically shown you the numerator and the denominator for this rate. So in blue, we've got the DDDs that we discussed earlier, so antimicrobial consumption. And in red, we've got admissions to COH. So you can see that overall our antimicrobial prescribing went down, but the number of admissions that we had went down further. So overall, our rate of prescribing went up. And as our admissions to hospital goes up, you can see that our rate of prescribing goes up as well, but that it has stabilized from that initial spike. We see similar results for carbapenem consumption, carbapenem obviously being one of the watch antibiotics, so we're always interested in it, and also CUH has always had an above average a carbapenem consumption. That isn't necessarily a bad thing. It's dependent on specialty, and the fact that this is a tertiary hospital explains a lot of that. And you can see that with the carbapenem use, there's a little uptick here towards the end. A lot of that in CUH has actually been explained by the expansion of our ITU capacity. So again, not necessarily a bad thing, but definitely something that we'll be monitoring as a trust going forwards. But now, so we've said a lot of COVID-19 patients don't get bacterial infections, but if they do, what kind of infections do they get? And these pictures are actually from a paper that was conducted in the States. So the percentages don't quite apply perfectly to the UK, but it was the prettiest graph. And the types of infections apply. So in terms of community onset, so coming in with a bacterial infection, it's our usual culprits that show up, strep pneumo, Haemophilus influenza, Staph aureus, so not unexpected findings. And as you stay in hospital for some time, these change to more of a gram-negative sort of spectrum. So for respiratory infections, you've got Pseudomonas, Klebsiellas showing up, you've got E. coli and Enterobacters, and in the bloodstream, you've got a very similar situation, also with coagulase negative staphs, which are often line related, so showing up as well. This graph is a study that was carried out at the Imperial Hospital Group in London. It's a bit of a busy graph, so I'll talk you through it. Basically, in the red, we've got hospital-acquired bloodstream infections in ICU. So that's the red graph. In light blue is ICU admissions, and the black line is the sort of percentage of bed occupancy, and you can see that we are going above 100% occupancy, both in the first wave and consistently during the second and third wave. And this shows quite convincingly, I think, that as the ICU capacity increases and goes, particularly when it goes above, the expected percentage capacity, a couple of weeks later, you get an increase in hospital-acquired bloodstream infections. And as this paper points out, there was an increase in bed occupancy in ICU, but actually staffing level-wise, particularly nursing staffing level-wise in ICU, this remained the same. And I think this is the experience that was quite similar throughout the country. I think we experienced it here as well. And prevention of both ventilator-associated pneumonia and bloodstream infections in ITU relies on strict nursing and infection control policies. And the moment you put a system under stress, that there is a breach in maintaining these standards. And this is by no means limited to the UK. The same stories came out of the States and Italy in particular having significant MDR rates and having outbreaks of multiply resistant infections such as KPCs and carbapenem producing Klebsiellas. And in addition to that, we have proning practice, which hasn't really been done as much in ITU prior to this. We've got increased use of PPE with long gowns that can impact on hand washing practices. And also, obviously, these patients are on ventilation for a long period of time. I'm going to quickly talk about ventilator-associated pneumonia. I don't have much time at all, but I had to include this study, which is an absolutely brilliant study, which was led by ICU colleagues here in CUH and was done in our own ICU. So what they looked at here was COVID-19 ventilated patients versus a cohort of similarly ventilated patients during the same period that did not have COVID-19 and were ventilated for a different reason. And the included cohort was from March to August 2020. So this is actually quite a lot, mostly before our use of immunomodulatory drugs has really come into effect for COVID-19. And what they showed here was that there was a significantly increased likelihood of developing VAP in COVID-19 patients, which wasn't fully explained simply by the duration of the mechanical ventilation. So there is definitely something extra in the pathophysiology of COVID-19 that we are yet to potentially explain. So this is my last graph that I'm going to show you. You will remember I showed you this at the beginning. This is the same graph, but I've now included 2020 and 2021 data. So C. diff rates, you will see that they've sort of plateaued here. Actually, if you, I haven't included it here, but if you put a few more of the dots on, there is actually a slight uptick here. And there's a big concern that given the broad spectrum antibiotic use, we might actually get a sharp rise in C. diff rates over the coming months. But what's happened to the rest of our bacteremias, really? So this is MRSA bacteremias have gone down. MSSA and E. coli bacteremias have gone down as well for the first time since we started measuring them. And Pseudomonas has remained much the same. So the only one bucking the trend is Klebsiella bacteremias that have had an uptick. And really a lot of this, I'm sure, will be explained by changes in access to secondary practice, maybe also changes in, the amount of surgery that we're doing, which plays a significant part, for example, for MSSA bacteremias. But I don't think this has been yet completely understood. And we also do not know what the trend will look like after this as we return to normal and as people start accessing secondary care again. And as I've already alluded to, this uptick in Klebsiella bacteremias is seen both nationally, but also at our own CUH data. So I'm sorry, I'm running a little bit over time. I just have a few take-home messages to say the majority of COVID-19 patients do not have bacterial infections. I think we're quite lucky at CUH that we have, for example, access to things like microarray. I think diagnostics are key to improve our confidence, particularly as we start using immunomodulatory drugs in COVID-19 to actually have the confidence to stop antibiotics. The trends in our mandatory reporting healthcare-associated infections have had huge changes. I don't think we completely understand all of those changes and what they mean and why they've come about. And finally, infection control practices and antimicrobial stewardship remain key. What I've got here on the right, if you have a moment, please do go to antibioticguardian.com. It is a website where you can sign up for a pledge. There's a whole long list of pledges. You can sign up as an individual, as a specialty, and basically to pledge something that you will do in the coming year to try and tackle antimicrobial resistance. This is, I'll leave it up here, is the upcoming plan for the week. Thank you very much for your time. And I'm sorry I overran a little bit. Any questions at all?
Great, thank you very much, Sunny. Just to remind people to put questions in the chat if you have questions. I have a quick question to start with, Sunny. So I'm not an infectious disease doctor, so I'm not expert in this at all. But so you noted the decrease in bacteremic episodes during the last sort of 12 months or so. And obviously that, as you say, could be due to decreases in surgery, admissions to hospital, perhaps even the decrease in population mixing. But I think the incidences of antibiotic resistance infections went up during that time. So is that because these bugs that are antibiotic resistant are generally fitter in terms of a competitive sense in causing infection? So beyond the use of antibiotics, they themselves have some kind of competitive advantage when it comes to causing an infection over other bacteria. So what explains that increase during this time?
Yeah, I don't think that change has been fully explained. And I think what's difficult is that we often think about, so for example, the gram-negative bacteremias, we think of them as one beast. And actually each component, for example, E. coli bacteremias versus Klebsiella bacteremias have very different both epidemiologies and different interactions with healthcare systems. So, for example, E. coli bacteremias are primarily 80% are community acquired, whereas with Klebsiella, they're more healthcare associated. So I think we will need to break down the individual components to genuinely understand both how whether what we're measuring is simply they are the sicker ones, therefore they're the ones that we're seeing and we're measuring at the moment, and it's all a matter of measurement, or it has something to do with our change in antimicrobial use during this year. I don't have, it's a very politician answer I've just given you. I don't have a direct answer, but I think we will have to think of it as individual components rather than as a whole for each of the infections.
Okay, great.
I think Dr. Gouliouris and Dr. Brown are also on the call. They were obviously, I forgot to thank them at the beginning, which is terrible of me. They helped to with this talk greatly, and please do jump in if you have anything to add, or any of the other microbiology colleagues.
Maybe they could put some comments in the chat. We've got some more questions.
Yep.
So I've got one from a couple here. So one from Caroline. I'm going to read, on initial presentation of patients with COVID, it can sometimes be difficult to tell whether or not there is a superadded bacterial infection. Any tips when to send procalcitonin? Yeah.
So I think it's useful to have that co-infection number in mind to say that actually your pre-test probability, if you will, is actually quite low. Having said that, I think it's absolutely right to prescribe antibiotics if you're unsure, but perhaps what we need is to be reviewing them early. So once you have the chest x-ray back, once perhaps you've also sent a procalcitonin, once you've got an overall picture of the trajectory this patient has, not in the first necessarily 2 hours of your ED, but in the first 12 hours, actually, can we stop the antibiotics? Even if we've had to start them because the patient seemed very unwell, we can reduce our antimicrobial use also by reducing the length of treatment that we provide. So I don't know, I think Theo obviously will have very, very strong views on this as well. So I don't know what you think about procalcitonin use.
Oh, hi, I'm not sure you can see me. Thanks, Suni. I think what I would say is that procalcitonin is not yet recommended nationally, although there are studies that have used it and have found, mainly in the ITU setting, the ones I've seen, and they found it helpful in stopping antibiotics without any adverse evidence and adverse outcomes. What we are interested at the moment at doing locally, and we'll be looking at in more detail, is how procalcitonin correlates with the macroarray results, because we're in a unique position to be able to do that. So that's something we're starting to look at the moment. But in terms of what we have, before we can really with confidence say to start using procalcitonin on the wards, we have the current NICE guidelines, which really look at markers such as purulent sputum, focal infiltrates, neutrophilia as the characteristic markers of a bacterial infection, really to steer us towards using antibiotics or not. The duration is of antibiotics that Suni just mentioned actually is a wider issue. And that in terms of community acquired pneumonia, there's now very good evidence that 5 days is sufficient for most bacterial infections, for most patients with a bacterial infection and pneumonia coming from the community, as long as they have achieved stability by day 5. And this has been validated in a number of studies. But that said, COVID is, the difficulty with COVID is clearly the rise in CRP, which is a mark which we normally rely on in other viral infections to differentiate between viral and bacterial causes.
Great, thank you. We've got time for one other question, but just a quick answer, please, Sunny, and that's from Lalita, and is, do you think a pledge is useful versus rules? For instance, how are you assessing the efficacy of measures to prevent infection, also nosocomial infections such as hand washing and other infection control methods, versus what about antibiotic prescription guidelines, algorithms, etc.?
I think a pledge, the benefit of a pledge, shall we say, is that it brings us to think about what we individually can do. Obviously, all the rest of what Lolita's mentioned, Dr. Ramakrishnan rather, is very relevant and is still being undertaken both by infection control teams or micro teams and as a trust level as well. But I think it can be easy as individuals to think that we have nothing to add, and really it's our individual practices that can make a big difference. So that would be my suggestion for the pledge.
Great, thank you. And there are a lot of other questions and comments in the chat, Sunny, so you might want to look at those and respond to those, but we're going to have to move on for time. So thank you, that was really good. And here's to the start of Antibiotic Awareness Week. So for our second talk, I'm delighted to welcome Drs. Elaine Jolly and Andrew Winterbottom, who are going to talk about a narrowed down diagnosis. Are you there?
Hello, yes, sorry, just loading up the presentation. Well, thank you very much for that introduction. My name's Elaine Jolly. I'm one of the...
Elaine, you might want to put it onto the presenter view again. It just is switching you over. Yeah.
Let me just double check.
That's it.
Is that the one?
Yeah.
Ah, okay, that's fine, we'll swap screens, right? So thank you very much for the introduction. My name's Elaine Jolly. I'm one of the consultant nephrologists and acute medics. This is a presentation with my acute medicine hat on, and I'm delighted that Dr. Andy Winterbottom is sitting here with me, who's my co-presenter for this interesting case. We're going to walk you through a clinical case, and we've left the title of it relatively obscure for obvious reasons, so that we can walk through what was ultimately quite a tricky diagnosis to clinch and involved a bit of detective work. So we'll start with the case history. The presenting complaint was a 25-year-old male who had bilateral leg pain and swelling. The background was he was a pilot with the Royal Air Force, was a non-smoker, drank minimal alcohol and used no illicit drugs. He was previously very fit and well, a very fit individual with no past medical history of note and no regular medication use. Delving in a little bit more to the presenting complaint, 2 weeks prior to the admission, he went on a wilderness training session with the RAF in Norfolk, and this involved lots of long hikes. He carried his own equipment, he did wild camping, constructing their own shelters and foraging for food to eat. He did, however, have clean drinking water, and there was no wild swimming involved. He ate wild game, which they cooked themselves over a fire. And he did describe multiple insect bites. He wondered if they were horseflies and described lesions such as this that arose on his back. Then a week prior to admission, he went on a long motorbike trip, which was several hours duration, and during which he carried a very heavy backpack. He then shortly after developed some lower back pain and attended an osteopath who did some spinal manipulation, and this pain seemed to settle somewhat after a few days. Then 3 days prior to the admission, he developed the bilateral symmetrical progressive leg pain, which he described in his own words as cramping in nature. There was some swelling initially, but then this quickly resolved. But the predominant symptom was that of pain, and he was unable to walk due to the pain, which prompted his admission to hospital. And he'd been taking regular paracetamol and ibuprofen for this. On a systems inquiry that was positive for intermittent fevers, which were mainly nocturnal. He also had some non-traumatic bruising to his abdomen and had reduced eating and drinking intake, mainly mobility related, unable to cook for himself properly. He had no other symptoms, in particular no GI, no GU, no testicular symptoms, and no cardiorespiratory symptoms. In addition, he had no typical COVID symptoms, and he described no weight loss. There was nothing from his family history of note. On examination, he was curled up in bed in pain and unable to straighten his legs. His temperature was 37.9, so borderline elevated, and he was also nearly tachycardic with a heart rate of 99, although the rest of his observations were all fine. His heart signs were normal, his chest was clear, there was no edema. Abdomen was also soft and non-tender, but there were some very small petechial hemorrhage lesions in both iliac foci. He was neurologically intact with a GCS of 15, but he had marked pain on movement of both legs. There was no spinal or paraspinal tenderness. Initial investigations at this stage in the emergency department were a venous blood gas, of which really the only remarkable feature was a mild hypokalemia. Biochemistry-wise, his renal function and liver function was completely normal, but he had a marked rise in his CRP at 294. From the hematology perspective, he had a mild normocytic anemia, and although his total white cell count was normal, he did have a lymphopenia and a mild neutrophilia and monocytosis. His eosinophil count was normal, as were his platelets. His prothrombin time was slightly elevated, prolonged at 18.1. Paradoxically, his APTT was very mildly shortened at 24.5. His ECG was normal sinus rhythm with a rate of 95 beats per minute and no other adverse features. So the working diagnosis at this point was a young gentleman with a febrile illness with associated myalgia and myositis, a raised CRP and a lymphopenia. The differential was between potential inflammatory sources or infectious, and COVID was up there in a differential versus other viral versus other bacterial etiologies. He was rated as amber and admitted to Ward N2 for further workup. The mildly raised PT was slightly unexplained and was potentially thought to be ibuprofen related, and for this reason, prophylactic low molecular weight heparin was not prescribed. Further investigations and management that were instituted that night, this gentleman arrived at 1 o'clock in the morning, were a COVID swab, viral throat swab, blood cultures, and this gentleman went on to have 4 blood cultures over the space of the next 48 hours. A procalcitonin was checked, as well as autoimmune profiles, including ESR, anti-neutrophil antibody, complement levels, and a myositis screen. He also had a total creatinine kinase, a magnesium, and thyroid function checked. He was given intravenous fluids with potassium replacement, given his mild hypokalemia, and some paracetamol and Oromorph for pain relief. So I met him the following morning on my post-tape ward round on Ward N2. We went through his history again, and he did describe these insect bites that he'd had during the survival training. These had all healed up. There was nothing to see at the ward round, but I reviewed some photos on his phone and could see about 7 erythematous lesions, about 2 centimeters in diameter on his back. He also described receiving the Pfizer COVID vaccine, the first dose of which 3 weeks prior to presentation. He'd had no recent foreign travel and was in a stable monogamous relationship with a female partner. Important negatives on examination: he had no lymphadenopathy, no jaundice, no clubbing, no splinters, or any obvious pallor. His abdomen, there was no organomegaly or discrete mass palpable. He did have some fine reticular bruising bilaterally from the flanks extending down into the groin. I don't think this clinical picture really points it out, but this picture was taken, a clinical photo was taken within 24 hours of admission. He had no hernia, his testicular exam was normal, but I did describe some tenderness in the groin medial to his femoral artery with a palpable cord-like structure. On peripheral examination, all of his lower pulses, limb pulses, were present and normal. He had some mild swelling in his calves bilaterally, but importantly, there was no muscle tenderness, although there was some mild tenderness, which is more in keeping with venous territory distribution. He had no pitting edema, and he was unable to completely extend his leg. And when we got him up to walk, he had a very shuffling gait and had to return to bed very quickly due to pain. Observations available and further tests at the post-tape ward round: his COVID Samba PCR was negative. His ESR was also slightly elevated at 54, and a procalcitonin was normal at 0.18. This is what happened to his observations, and you can see that there was a temperature spike shortly after admission to 39. His heart rate settled nicely with some IV fluids overnight, and his blood pressure and respiratory rate remained stable. This is his chest x-ray, and I think you'll agree that he's got clear lung fields and normal cardiomediastinal contour, and a total CK came back as completely normal at 34. So we had to make a new clinical impression at this point, and the differential, to my mind, remained wide, and it did include inflammatory and infective etiologies. I felt myositis had effectively been ruled out with a normal CK, and although he had fever and raised inflammatory markers, he had a normal procalcitonin. He had bilateral leg pain and swelling in the venous system distribution with preceding back pain. And clinically, I wondered if an IVC obstruction was the most likely unifying cause here, and I wondered about a pelvic mass underlying this. So we gave him some more intravenous fluids, and we repeated his bloods, in particular his coagulation profile. As you remember, the prothrombin time was mildly elevated prior to making a decision about low molecular weight heparin. We repeated his COVID swab because there was still an unclear diagnosis. He had an ongoing fever with no clear infective source. We consented him for HIV and hepatitis B and C testing and discussed him with our infectious disease colleagues. At this point, we held off antibiotics as there was no clear infective source and he was clinically well despite the CRP, and the infectious diseases team were in agreement with this decision. But we wanted some urgent imaging to work out further what was going on, and we felt the most likely test to give some useful information would be a CT abdomen and pelvis with some venous phase views to try and demarcate both potential vascular and MSK pathologies, as well as show up a pelvic mass lesion. And this was arranged for later the following day. I'm just going to hand over now to Dr. Andy Winterbottom to discuss this further.
So you'll see the video of the CT playing. As we come down, lung bases are clear. A normal liver, spleen, you can see the stomach in the left upper quadrant. Coming through the pancreas and the kidneys, they're all normal at the moment. We've got a normal aorta and IVC appearing, and the bowel is normal. Abdominal wall and musculature are all normal, but as we're coming into the pelvis, you can see the aortic bifurcation, psoas muscles, and we've got large distended common and external iliac veins. You'll see lots of body wall edema, lots of limb edema, big dilated iliac veins. So diagnosis at that time made was of iliac DVT bilaterally with limb swelling.
Brilliant. So at this point, we felt we had a diagnosis. It was an IVC thrombus with near occlusion of both common iliac veins and likely extension to more distal lower limb veins. And the Doppler ultrasound the following day did indeed confirm complete occlusion of the deep veins of the calf and the thigh bilaterally with thrombus, which extended into the external iliac veins. Importantly, there was no evidence of compressive abdominal or pelvic mass on the CT. So there then followed a discussion with the hematology team, and they suggested correcting his prolonged PT with some vitamin K orally for 3 days, whilst also commencing treatment dose low molecular weight heparin, that is dalteparin. But the impression was very much that we needed to extensively investigate for a potential provoking insult or pathology in this young, otherwise very fit patient. So why do patients have venous thromboembolic episodes? Well, this is a very common pathology, as I'm sure everybody is aware. And our acute medical clinic 5, the ambulatory care clinic, commonly sees several cases of either DVT or pulmonary embolism per day. But it is rare to require admission with a DVT, and it just demonstrates the extent of it for this young man. And I think when thinking about VTE episodes, it's useful to think back to Virchow's triad, which was named after the German physician who described many of the earlier scientific work into venous thromboembolism more than 150 years ago now. And the 3 components of it that can each cause problems leading to thrombosis. And they are venous stasis, activation of blood coagulation or hypercoagulability, and vein damage or vessel wall injury. So as I mentioned, in this young fit patient, there was no clear, obvious provoking factors. So we worked through each of these 3 potential causes. With hypercoagulability, some liver infections can lead, particularly liver sepsis, can lead to VTE episodes. So we organised a liver ultrasound for him, which was normal. Underlying inflammatory disorders are risk factors, such as inflammatory bowel disease, but again, there was no suggested history here. Nephrotic syndrome, where heavy proteinuria leads to loss of the appropriate clotting factors, can lead to VTE episodes as well, but his urine dip was entirely bland with no proteinuria at all. Underlying malignancy is certainly a consideration, although his abdominal and pelvic CT was blameless from a malignancy perspective. We went on to do a CT of his chest as a precaution, which was also normal. Trauma and certain medications, including estrogens, can also increase coagulability. What about inherited thrombophilia? After discussion with our hematology colleagues, we ordered a whole screen of tests to screen for potentially lesions such as JAK2, PNH screen, a thrombophilia screen, which included antithrombin 3, protein C activity, free protein S antigen, all of which were completely normal. He had an autoimmune screen, ANA complement and ANCA levels, which were all normal. The only slightly raised result was a fibrinogen of 5.23, which was undoubtedly just secondary to the acute phase response. We also looked for potential antiphospholipid syndrome with lupus anticoagulant, beta-2 glycoprotein 1, and anticardiolipin IgM and IgG, all of which were entirely normal.
Elaine, sorry to interrupt.
Yeah.
I don't know if you're moving your slides on, but they seem to have frozen.
Ah.
And might not. I can just see a slide just saying diagnosis.
Oh, really? They've moved on from me. Is that a? Is that
I don't know if anybody else is online. I just saw somebody in the chat also say that it's frozen.
Screen sharing is paused. Resume share. How many slides have you missed?
How many slides have you missed? I think something has happened. It's frozen.
Okay.
There we go.
No, that's fine.
Fine.
Yeah, that's
So
good. Yeah.
Anyway.
Fine. So we'll just keep moving on anyway. Apologies for that. So essentially blood tests were all normal. And I would just mention quickly the vaccination side of things. The patient himself and his family were worried about vaccination as being a contributing factor. This is obviously a whole talk in itself. So a very quick slide that Dr. Will Thomas kindly pointed me towards, looking at the risk of venous thromboembolism after COVID-19 vaccination. This was a large study involving 30 million patients receiving their first dose of either the Oxford AstraZeneca vaccine, Pfizer vaccine, or indeed having COVID infection, with some outcome measures that were designated looking at electronic health records for these individuals. And you can see from here that along the x-axis, the incidence rate ratio is anything above 1 is an increased rate of that clinical outcome, which is down the left-hand side here in the columns. And you can see that venous thromboembolism, if you look at the orange dot and the line, which is the Pfizer vaccine, is not associated with any increase in venous thromboembolism. COVID infection itself certainly is, and the Oxford AstraZeneca vaccine was mildly associated. So we can discount vaccination here as being an issue. Vessel wall injury, well, none of those factors applied to this patient. Vasculitis was worth thinking about though, because he did have an elevated CRP and fever. And then the rest of the factors, well, nothing obviously jumps out as being relevant for this young man. So his progress. He remained poorly ambulant. He was able to hobble, but was still described significant thigh swelling, heat, although no compromise to limbs. And importantly, he had no symptoms suggestive of PE. At this point, a vascular surgery opinion was requested. Of all the results, as I mentioned, no positive results to suggest an underlying provoking condition. So I spoke to one of my colleagues, Dr. Lisa Wilcox, for a vasculitis opinion, and she agreed this was unlikely. The acute immunology screen was negative, no nephrotic syndrome, and no suggestive history. And she suggested re-review of the CT images by a vascular radiologist to see whether further imaging such as PET-CT might be indicated. And we'll pass over to Andy for a review of these.
So what you can do now is when I came to see this patient, you'll see that I went through the CT and had a slightly different opinion to initial diagnosis, and I've highlighted several slides here. So behind the cava, you can see there's a huge number of large veins in the azygos and hemiazygos territory. As we come down further, you can see huge paraspinal veins. These are within the vertebral, the spinal canal outside the dura. As we come down further, no normal left renal vein, multitude of renal veins. You can see again large paraspinal veins. As we come down further, you can see one of these very large paraspinal veins draining across the midline towards the cava. You come down further and we've now got no normal IVC. There are 3 or 4 small channels, and you can see huge, these big paraspinal veins, paravertebral veins. We come down further and you can see there's no normal IVC. There are 3 or 4 different venous channels with clot in, and there's also a large paravertebral here with clot as well. When we come down to the pelvis, yes, there are big iliac DVTs bilaterally in both the internal and external systems, but my opinion from this was that there's clearly an abnormal underlying venous system, multiple shunt vessels, and you'll see from this video and the still that the IVC at the level of the aortic bifurcation is non-existent. So from that opinion, I can see that this gentleman doesn't have a normal venous system. He's got absence of a normal IVC and loads of clot in multiple collaterals as well.
Fantastic. So thank you very much. So the clinical picture was indeed starting to piece together massive bilateral ilofemoral DVTs, either secondary to a previous iliofemoral DVT, but this is unlikely. There was no previous symptoms or any pediatric history to suggest line insertions as a young child that could have precipitated vein injury. It was likely this is a congenitally absent stenosed IVC and iliac veins. And the minor provoking events, such as the suggestive of dehydration during the survival wilderness training or the long motorbike journey, had indeed provoked this acute presentation. It was discussed his case in a vascular MDT just 3 days after diagnosis, with 5 consultant surgical vascular surgeons involved. And their management plan at this stage was that if he cannot get out of bed and walk, he should be considered for catheter-directed thrombolysis to bring back to his usual good baseline, and then he could be considered for stenting as a chronic patient. The advice was strict high elevation of both limbs, compression bandaging, flotrons, and anticoagulation. So he was started on all of these measures. His legs were reported to be softer, swelling reduced, and there remained no acute vascular compromise concern. He did manage to mobilize a little bit out of bed, but with significant discomfort. Again, a clinical image of how things were looking at this stage. At this time, the prospect of catheter-directed thrombolysis was introduced and outlined to him. I should say that the infectious diseases team were very helpful over this time. He still had a high temperature and CRP rise, but there was no target for biopsy and no evidence of deep infection. A week after admission, he was still unable to walk properly more than a few paces, and even with that, his hips and knees remained partially flexed. He was deemed very high risk for significant post-thrombotic syndrome, and as the lysis window threshold was approaching, he was consented. The risks of catheter-directed thrombolysis were discussed, but he was consented for catheter-directed thrombolysis 8 days post-admission with alteplase. And we have some images to look at now.
So just a couple of early slides, you can see multiple filling defects in this static venogram, and day 1 lysis, you can see no flow in the femoral vein here. This is the second day of lysis. You can see partial recanalization with some collaterals, and then the third day of lysis, you can see we've got virtual complete recanalization. So we managed to restore flow in his femoral veins and his iliac veins, but you can see there's no normal caver at the top. So hopefully we lysed all that acute clot and got him somewhere back to what his normal baseline. Quick few slides on the evidence for catheter-based thrombolysis. There's a trial here, Cavant trial, some years ago, multi-center. They took patients with clot and they gave them standard treatment of anticoagulation versus catheter-directed lysis, and they showed a very small improvement with a significant p-value of the catheter-directed lysis in the prevention of post-thrombotic syndrome and patency. So small margin gain. However, the diagnosis of PTS is a bit controversial, and even with a score of 5 to give you post-thrombotic syndrome, you can see that you only have to have a little bit of pain, some heaviness, perhaps a bit of edema. So the diagnosis of PTS on the scoring system used can be quite soft. A more recent review of that actually then showed that there was no quality of life difference. So whilst you got an improvement on the scoring of PTS, the quality of life was no different. A more recent trial, Attractile, tried to relook at this. So they were trying to recruit iliofemoral DVTs to either catheter-directed lysis and stenting or conventional treatment, but they failed to recruit enough patients and included lots of femoral DVTs as well. But essentially they found no benefit. There was equivalent numbers of getting what they were diagnosed as PTS. So the most recent guidelines are that you could consider treating these big iliofemoral DVT patients, but the evidence is pretty weak. So for the prevention of PTS, we're still not sure, because only around 40–45% will get them.
Thank you. So last clinical update now. This gentleman had an uncomplicated procedure. As we've seen, he had a good improvement in clot burden, both 24 hours later, and then after some catheter repositioning, a further venogram at 48 hours showed an overall good result. Lysis was stopped and his mobility started improving, such that he was discharged home on day 11 with treatment dose low molecular weight heparin to continue. He was seen in Mr. Gohel's vascular surgery outpatient clinic 1 month later, when he had good improvement, still some calf swelling, but walking was much better. He was switched to apixaban and class 2 below knee stockings, and the plan was to continue DOAC long term. However, what would be the options if he develops chronic symptoms?
Now, one of the reasons we're not rushing in to lyse and treat lots of patients is we've come at this from a different direction. We're treating a lot of the chronic post-thrombotic syndrome patients, and here's a case. You can see here that this patient's got a huge number of venous collaterals, and their legs are actually draining via 2 methods, one via the ovarian vein, but they're actually draining via the inferior mesenteric vein to the portal vein. and we can actually stent these patients to recover normal flow. So we can take patients with huge numbers of collaterals and do iliofemoral stenting and get normal flow back. So we're happy letting the patient sort themselves out as to who's actually gets post-thrombotic syndrome and treat them once they've got the post-thrombotic syndrome.
Brilliant. So just final slides of some final thoughts and conclusions. This was a challenging case. It was a young, very previously fit young gentleman. And although the diagnosis was secured and treatment was started within 24 hours of admission, we did feel that it took a while to clinch the underlying final diagnosis. And this required many further tests for the patient, review of existing investigations, and really good specialty involvement and collaboration. There were so many red herrings, unexpected clinical picture. I myself was surprised that a temperature of 39 and CRP greater than 300 could be caused by extensive clot burden alone and not an underlying infective or inflammatory condition. What we held our nerve despite a temperature of 39, greater than 39, and CRP of greater than 300, and didn't give antibiotics. So this falls maybe quite nicely after the last talk we've just heard. It's a very common diagnosis, DVT or venous thromboembolism, but we felt this is a very rare presentation and worthy of discussion. It involved a continual readjustment of the diagnostic and assessment process and appropriate re-review of imaging when the clinical picture was not fully explained. And I think it would highlight the great multidisciplinary team involvement, specialty involvement that we experienced in the management of this patient's case. So I'd like to just conclude by acknowledging the various inputs from the various team members, particularly Dr. Winterbottom and his colleagues who performed the thrombolysis. Vascular surgery, Mr. Gohel was the consultant in charge, our hematology colleagues, infectious disease teams, vasculitis, and then all the other departments that are involved in a patient's rehab and indeed diagnostic workup. So thank you very much. I'd be delighted to take some questions.
Great, thank you very much. And sorry you had a bit of a slide issue. There's a couple of questions in the chat, and we can obviously provide the questions to you because we know I have to finish it too. I had one quick question. I'm a humble pediatric oncologist, so what do I know? But I may have missed it, but with the lymphopenia and hypercoagulability, obviously there's an anatomical defect, but was Lyme's disease ruled out given the bites that this man had?
Yeah, exactly. That was one of our thoughts, and that's why I was quite keen to review the images of the lesions that this young patient had experienced. They'd all healed up at the time we saw him, but yes, the time frame would have been potentially fitting with that. So yes, the full infectious diseases workup was completed and negative.
Okay, so there's a question here, which what is the explanation for the raised PT of 18 on admission, and what is the rationale for giving vitamin K plus endelapitorin at the same time?
Yeah, so I chatted to Dr. Thomas about this. I don't know if he's actually on the call at the minute, but the PT prolonged is probably due to factor 7 consumption was his explanation. It's often seen in sick patients, he described. Now this patient, albeit with significant symptoms, wasn't particularly sick, I have to say, but he clearly had a massive acute phase response going on with his coagulation cascade. And Dr. Thomas felt that actually factor 7 consumption would explain that prolonged PT. The rationale for giving vitamin K, I presume, is just in case there's an additional component of vitamin K deficiency sort of superimposed or in parallel to the extensive clot, hence why correcting that whilst simultaneously giving the correct treatment for an extensive DVT. But I'd be very happy if a clever hematologist is on the line and would like to expand on that.
There is a hematology perspective actually in the chat as well to read. And then another question is, with such extensive DVTs, it is interesting that they did not have a PE. Is there any ideas why this patient didn't have a PE?
So the patient's probably filtered himself already because he doesn't have a normal IVC. So that picture we showed where you've got those multitude of small veins, whilst they all connect back to the venous system, large clots can't travel up them. So the underlying reason for the cause of the extensive DVT is protecting him from large PE.
Great, thank you very much. I don't see any more questions in the chat, and we're about 2 minutes to go, so fantastic. Just thank you so much. It was a really interesting case, both to Andy and Elaine, and of course also for our antibiotic talk earlier on. So thank you very much, everybody. We're at the hour, and it's great to see you all. Take care.